All right, so we're going to keep moving on. Dr. Del Monte is going to remain at the podium and discuss surgery for third nerve palsy.
All right, well, obviously, third nerve is one of our more difficult conditions to treat. So I'm not going to tell you about all there is to know about third nerve palsy and surgery in 6 minutes. It's the most complex and difficult of our palsies. 4 of the 6 muscles plus the levator, the pupil and accommodation can be involved. Again, typically, you've got the XT and the hypo, the down and out eye, horizontal and vertical incompetence, ptosis with poor Bell's phenomenon, incombinant diplopia under binocular conditions, and sometimes aberrant regeneration, misdirection. Surgical treatment, again, that we might consider recess-resect procedures with augmentation, with transposition. I think you'll hear about some of the more complicated ones in the next presentation. Transposition procedures alone, either rectus muscles, superior oblique, torsional procedures, and a combination are required in many patients. But I think there's a better choice in select patients, and I'm going to present that now. Again, this is a 7-year-old girl with exodeviation in a left droopy eyelid since infancy. Past medical and ocular history is unremarkable. Visual acuity, normal on the right, and on the left, she has a mild amblyopia, secondary probably to her strabismus as well as to some anisometropic astigmatism. And here are her measurements. She's 30 to 35 diopters of left exotropia and 15 prism diopters of left hypotropia in primary gaze, with decreased adduction, elevation, and depression, more reduction in elevation and abduction. She also had moderate left ptosis, which increases on left gaze and disappears on right gaze. And again, that's the key to this particular treatment modality. And she had no pupillary problems. And here you can see her, as much as we had of her 9-gaze position. And you can see in primary gaze, can I get the arrow here? In primary gaze, she definitely has a left hypotropia and an exotropia. And again, it's hard to illustrate this with pictures because it was more impressive most of the time. And a left ptosis. The left ptosis got worse in left gaze, as did the left hypotropia. In right gaze, the left ptosis resolved almost completely, and the exotropia increased. So again, a typical patient with congenital partial left third nerve palsy with an exotropia and left hypotropia worse in left gaze, aberrant regeneration of the left medial rectus to the levator of the left eye and also to the left superior rectus, and a moderate left amblyopia. So the question is, what kind of treatment should we prescribe? And again, most of us probably would have selected a left lateral rectus recession, left medial rectus resection, maybe with superior transposition, with plication of the superior rectus, maybe with recession of the inferior rectus with the potential increase in anterior segment ischemia risk. And then once they heal completely and you're happy with the alignment, do a left ptosis repair with, again, increased exposure risk. But I'm going to suggest a better choice in these patients is the combined correction of strabismus and ptosis by doing a recess-resect procedure on the uninvolved normal eye to use the misdirection to correct the ptosis. Again, in selected patients, usually they have XT and hypertropia, or sometimes small hypertropias, and aberrant regeneration. How do you decide what to do? You can actually dose the surgery by putting base-in prism over the uninvolved eye in the office, as we see here, and it will cause the normal uninvolved eye to abduct, pulling the other eye in, and you'll see the lid position elevate, and you can actually compare the lid positions by eye and decide what the right dose of surgery is to correct the ptosis, in this case 45 prism diopters. And so you basically do exotropia surgery on the good eye. We did a right lateral rectus resection of 10, right medial rectus resection of 8, and we got an excellent result. Lid position was improved, and the eye alignment was very good as well. You can also use this in some of the more severely affected patients if they have significant aberrant regeneration, or aberrancy. And here you've got a patient with quite a large left hypotropia and exotropia and ptosis, really too large to do just with the good eye, but you can use the base-in prism over the good eye to assess the lid position, how much you needed to do on the normal side to use the aberrancy to correct for the lid position, to raise up the left upper lid. And then you put prism base-in over the other eye to determine how much you had to do to correct the strabismus. And using that combination, we did the surgery that you see listed here, and you can see the pre-op and post-op result was really quite impressive. So again, in selected patients, we're reviewing our cases now. We had 2 fellows from Egypt, and some of these patients were Egyptian patients. They did as well. We had 9 patients that we've done over the last about 10 or 12 years. And so it's not certainly in every patient, but it's been very useful in this select group of patients. So again, in summary, third nerve palsy with aberrant regeneration, consider combined correction of strabismus and ptosis with a recess-resect procedure on the normal eye. And I don't usually like to do surgery on the normal eye in a palsy or restricted patient, but this is a situation where I think it's really indicated. Since there's often some aberrancy from the medial to the superior rectus, you usually correct the hypotropia as well. So it corrects both. It reduces the risk of anterior segment ischemia, and since you don't have to do ptosis surgery, which is unpredictable, you also reduce the risk of exposure keratitis because the patients don't have good Bell's phenomenon. You have to remember, though, that most of these must be fresh cases. Once somebody's done a resection on the lateral rectus, resection on the medial rectus, previously on the affected eye, it's difficult to get enough correction on the normal eye to raise the lid properly without, and still correct the right amount of residual exotropia. Thank you.